So a new look, new being relative, at potential uses. Recognizing that this is something that's been culturally ingrained for a long period of time, but really looks to be having a resurgence here recently. So our objectives are going to be threefold. So to describe the mechanism of action, we're going to look at some conditions that psilocybin's been used for, and then evaluate some of the literature on how the psilocybin has worked for those conditions. Taking a step back though, officially psilocybin or mushrooms are Schedule I controlled substances. The definition of Schedule I is that there's a high abuse potential with no recognized legitimate medical indication. I wanted to highlight that because specifically for this, it's a little bit different. So psilocybin's not been recognized to be naturally addictive. Usually we think of Schedule I substances as something with a high abuse potential, as a problem for diversion and misuse. That could be addictive, but that's not what they've seen with psilocybin. In a number anecdotal information just on use rates across the country in adults, they do use psilocybin. It tends to be a little bit more intermittent, but we'll talk about that. In animal studies, it's not found to be as reinforcing. So when given the option, the animals will not preferentially choose this over other options. So it doesn't seem to have the same addiction potential, even though it is Schedule I. I think that's going to be important as we talk about some of the safety pieces here later on. In looking at how commonly this is used, the National Survey on Drug Use and Health that looked, I believe the data was 2009 through 2015, the lifetime prevalence of use of mushrooms was about 8.5%. So this isn't necessarily consistent use, it would be any use in lifetime. So not necessarily something that's not used, but maybe not the most commonly used on a regular basis. So what does psilocybin do? It is found in a number of different fungus species, and the psilocybin itself is digested into psilocin. The psilocin has activity at a number of serotonin receptors. So similar to other psychedelics, it is an agonist at the 2A receptor. And this is thought to be where a number of those psychedelic properties come in. It also has activity at the 2C receptor. So it may not just be 2A, but this seems to be what's thought to be the predominant pathway at this point. By activating the 2A pathway, it can change a number of other signaling pathways. This goes with cognition, level of consciousness, perceptions, mood, appetite. It could do a number of different things, which may explain the variability that we see in a number of patients who use psilocybin. The effects, so for individuals who are using mushrooms in low doses, it tends to have sensory perception. It was fascinating to read about a number of the different perceptions that would occur. So some of these may be things such as visual perception, so the colors that are happening, the shape of things that may be slightly distorted, that there may be almost looks like wavers in the solid objects that people see, where it almost looks like they have an aura. It may potentially at low doses cause some hallucinations. Those may be smaller things, kind of setting up the synesthesia a little bit, but don't tend to be quite as upsetting as some of the hallucinations that may occur in higher doses. For some individuals, it can cause euphoria and spiritual awakening. We'll talk about its original use here in just a minute. And it can also cause some nausea and vomiting. Oftentimes, on some of the use sites that I saw, it did encourage individuals to have eaten at least a half an hour ahead of time. The taste of some of the mushrooms can be really bitter and upsetting for some patients. So they do recommend that they eat a little bit beforehand. In higher doses, patients could have synesthesia. So this is really multiple sensory organs responding. So it could be that you're seeing numbers or letters in color. It could be that you're that the sounds have a color, that the sights that you have are associated with a taste. So it's really an overlapping of some of the sensory input. There can be a distortion of perception, especially of space and time. And then there can be much more significant hallucinations. At higher doses, these type of hallucinations are not is often confused with reality, but might be much more potent. So for example, a low dose hallucination may be that the individual sees a hand come up and come up out of the ground and be in front of them so that they can put things on it and there's actually a table there. Whereas the hallucinations on the higher dose may be that there are creatures, that walls or things are melting, and it might be a little bit more outside of what's considered closer to the realm of reality. Some of these can be very disturbing, some of them not so much. At higher doses, anxiety as well as panic attacks have also been reported. One of the, original use, reported use of psilocybin has been with a number of, in a spiritual context. So it was used by a number of different cultures as an opportunity in some of their ceremonies for spiritual awakening. So a chance to focus, to have kind of an opening to the entire environment, to really look for some degree of transcendence. So taking in all of the input, getting more in tune with things, maybe filtering out some of the inputs that are interfering with a person's ability to function. So it had been a little bit more in that religious realm. It then changed where it's used more in a social culturalization, used on the club scene, when individuals go to raves. There's been a movement to have psilocybin, especially in low doses, incorporated into a number of other products for its wellness type activity. So the thought is, this is a nutritional supplement. It may be a superfood, and it's been incorporated into a tremendous number of products. I was shocked, which is why my search history is all over the map now. The reason I picked this topic is not because there were all those products that were available. I picked it more because there's been decriminalization across the US. So there's a handful of states that have allowed for decriminalization. Colorado, California, Oregon, Washington, DC. Oregon last November actually allowed it to be legalized in smaller quantities. So really moving in a direction that has much more accommodation for the obtainment and potentially for the utilization, at least of small doses of psilocybin. Because of that, I started down the path a little bit. You can order all kinds of different mushroom products. So I did do a screenshot from one of the websites where you can order your own mushrooms. You can order different mushroom growth sets. You can order products, powders, teas, things like that. And then there are a couple other companies that are available that are selling mushrooms to a number of health, wellness, and nutrition stores. So some of them are a component of other products. So it might be a component of food products. So like a rice pilaf mixture, it might be part of a tea set. It may be in a number of other products. There's quite a few that have been infused into beverages. So the root beer type beverages look to be one of the main flavors that they do use. It can help mask the bitterness of the mushroom, and apparently it's a good medium to deliver that. So availability has definitely increased. So it'll be interesting to see if that 8.5% lifetime use remains consistent or if we see a change. So recognizing that it's been used more socially, recreationally, what about on the medicinal side? So there are a handful of reported uses for psilocybin. Anxiety, and I have an asterisk here, so it's not just pure treatment of anxiety. It's specific treatment of anxiety for patients with terminal illnesses. Started with cancer, but did move a little bit to other terminal illnesses as well. Depression in the context of treatment-resistant depression and substance use disorder, the focus of the literature that I found was really related to nicotine dependence, although they have done some studies in alcohol use disorder, but I didn't find quite as much there. And then we'll just briefly talk about, because I didn't find as much, on obsessive compulsive disorder and cluster headaches. Before we get started though, I did just want to let you know, so this was not done in a context similar to other randomized double-blind placebo-controlled trials. Recognizing that this is a psychedelic, that individuals could have really negative outcomes depending on how they are. So I never used mushrooms, so I'm not speaking from personal experience, but there are a number of reports that expectations, so historical use expectations, as well as the environment and mindset that the patient's in, may actually influence the experience that they have during their trip, during the period of time that they're high. So when an individual ingests the psilocybin, it's about 4 to 6 hours that they're considered to be under the influence. So in preparation for this in a medicinal context, most of these trials set up a similar type of a schedule. There was preparation. So there were things that were put in place encouraging the individual to be in a good mindset for the session where they were going to use the psilocybin. When they were given the actual active product, there were a number of interprofessional supports used, as well as ongoing monitoring. Interestingly, in the recreational realm, they also encourage the use of non-using sitters. They call them trip sitters. So if an individual is going to use a mushroom, they should have someone who's not using, although it seemed like a lot of individuals who were sitters were using other substances like marijuana, but they're there to assist. So the one individual was talking about the fact that he is a regular user of psilocybin, but at some point during his trip, he will have an experience where he feels catastrophic, like disaster is coming, he's about to die. Usually his environment will turn into a jungle, and he needs that sitter as his checkpoint, because there have been instances where he was trying to get out of that situation and ended up not in touch with reality and getting himself in dangerous situations. So running out to be away from what he perceives as danger, potentially running into the street or things like that. In this context, they would have the individual work on certain things. So are there certain things the patient wants to explore, certain areas that they're hoping to open up? So somebody who serves as more of a guide. So really a complement to some of the motivational interviewing or cognitive behavioral therapy. They also were able to have some interventions on the monitoring side in the event that the patient began to panic when they're underneath the influence. And then there is a post-session debrief. So a chance to be able to reflect on what happened, maybe process some of those type things and help reset if there was any distress. So looking at the different indications, so for those with anxiety, there were a handful of trials. For course of time, I tried to be brief, so we're just gonna quickly go through them. Most of the patients in these trials were individuals with terminal cancer that were considered more on the hospice type track, although there were a couple that were allowed to be included that had other terminal diagnoses, but they didn't get into specifics. The first trial was a pilot study, so double-blind, it was placebo-controlled. They used niacin as the placebo control, so it was immediate release niacin that would provide maybe a little bit of stomach upset and some flushing so that it was something active, but not the same as the psychedelic. The outcomes that they were looking at were depression and anxiety. They used the Beck Depression Inventory and the State Trait Anxiety Inventory. What they found was, so this was a small group, so this was only I think 12 patients, and it compared to baseline at 3 months after they had used the psilocybin, they did see significant decrease in the anxiety scores. They also saw significant decreases in the depression scores, and that went all the way through 6 months. So compared to baseline, all of those depression scores were reduced and it was able to be maintained. There was no correlation between their outcome and how their cancer or other diseases were progressing. It was, so in those individuals, even though they were terminal, this was the main intervention that they thought had some type of an impact. The other trial was a double-blind crossover trial. So treatment was separated by 5 weeks. Again, they did use niacin. They used low-dose psilocybin. So again, the patient, had the sitter with them, had a debrief session. They used the Beck Depression Inventory. They used the Hamilton Depression Scale, the Hamilton Anxiety Scale. So they used a number of different rating scales. The main outcomes on the HAM-A and the HAM-D, they found 80% of patients at 6 months had some degree of improvement. So that was at least a 20% change from baseline. And at 6 months, they had 60% that were in remission. So that was more than a 50% reduction. So they were seeing pretty significant improvement that was maintained in this patient population. Interestingly, they looked at the characteristics of the patient's active treatment session. So during their trip, they found that those individuals that reported a sense of unity, a unity with their provider, with the universe, just a sense of unity in general, those that had more of a religious quality, meditative, they felt that it was sacred, it was a really positive experience, maybe they had a transcendent type experience, or even something that they couldn't explain, but that was really positive, and they felt that it was life transforming. Those were the individuals that were consistently correlated with the long-term response. So it looked like if they had this positive type of a reaction during the active treatment session, they were much more likely to continue to have benefit, at least for anxiety and depression long-term. So kind of interesting that they were in that supportive environment, and these were things that they found to be beneficial. How about for depression? So this was a pilot study in only 12 individuals with treatment-resistant depression. So they had failed at least 2 other treatments. They were given 2 different doses of psilocybin, and these were significantly higher than what they used in the anxiety. So in the anxiety, it was like 0.2 milligrams per kilogram and 0.3 milligrams per kilogram. Here they actually used just a straight off 10 milligram dose or a 25 milligram dose. From a tolerability perspective, there was no difference between the 2, but definite difference in their approaches to dosing. So just something to keep in mind. They did do follow-up at 3 months. Their main outcome was the Beck Depression Inventory, and they found that 67% of patients were in remission, so had a significant decrease of about 50% at 1 week after their second session. And then 42% of the patients continued to have, so I believe that was 5 of the 12 patients continued to be in remission 3 months after their session. They didn't look at the details of the trip, but they did continue to see some improvement. It was open label, so all of the individuals knew that they were using these substances, and there were no tolerability issues that were noted. Shifting gears a little bit to look at tobacco dependence. So this was also an open label pilot trial, so small number of individuals, so 15. Again, this was a weight-based dosing. So they received a dose of psilocybin on their quit date, and then they received a second dose at week 2. And then they had the option to receive a third dose at week 8. And then they continued to receive cognitive behavioral therapy support for the full duration of 10 weeks. They followed up with these patients at 3 months, 6 months, and 12 months. They reported their abstinence data at 6 months and 12 months. So 80% of the individuals were abstinent from tobacco use at 6 months, and 67% were abstinent at 12 months. So they did see pretty robust, consistent abstinence. Again, it was open label. There may have been a selection bias based on the individuals who were interested in trying, but they did see some improvement here. Just a quick look at the other 2 indications for obsessive compulsive disorder. This was a small pilot study. They used low doses. Of the 9 patients, 1 of them had significant long-term benefit. I believe it was at 6 months. They continued to see a significant change from baseline. but they saw lower rating scale scores on the Y box is the rating scale that they used here for all of the doses. But the researchers called that into question because that lowest dose was intended to be a placebo. So that was supposed to kind of be their control session to be able to compare the other doses. So they were surprised that they saw some degree of reduction in symptoms after each of them. So possibly it could be something that's beneficial. This was dosed each week, and then they were followed up a little later on, and they continued to have psychotherapy alongside. In the cluster headache, this was a case series. So they collected a case series of patients with cluster headaches who had used psilocybin, and they reported that they did have a termination of their cluster headaches and a reduction of the recurrence of these headaches. There was a larger survey that went out to look at patients with cluster headaches, and then there was based on the subjective responses of those 430 some patients, they did see that patients said that the psilocybin was equally effective of their other treatments, but we kind of need a little bit more systematic information. In both cases, there were no significant reports of toxicity that were reported. So efficacy-wise, there has been a little bit of information out there in looking at its use. Selected, so pilot type studies, really small studies. We need larger systematic studies, specifically those that are going to look at some of the safety options. So there are a handful of patients that have negative experiences when they're using psilocybin. So it would be important to be able to capture a little bit more how tolerable this is for a much bigger population, especially those who may be on other medicines or have other comorbid conditions. But it is something that is becoming increasingly available, and you may start to hear because it's being promoted pretty heavily in a number of different forums online. So I just wanted to take a quick look at that literature. So with that, I'm going to stop.